Все, включаем, да.
Good morning. I'm Robert Dunn, Cape Town, South Africa. I'll be presenting on our study on the impact of surgery in 921 degenerative spine patients, which were assessed by pre- and post-operative health and functional scores. I have no disclosures pertinent to the matter. Degenerative spine surgery is one of the major causes of disability, with poor quality of life and low productivity. The rising cost of surgery for this condition demands supportive outcome data, such as those from the patient's perspective. In this paper, we sought to describe baseline disability and quality of life of our degenerative spine patients across both the private and public platforms. Diagnostic subgroup analysis was used to determine which group gained more from surgery and whether which fusion technique made a difference. We studied the patient-reported outcome measures, PROMs, in degenerative spinal surgery by a single surgeon across both private and public platforms. This was over a period of care of 2003 to 2020, where patients who were assessed pre and at 6 months post-op in terms of the PROMs, including Euroqual 5D, Oswestry Disability Score, Roland Morris, and Visual Analog Scale. This included 921 patients with pre and post data. All had undergone decompressive lumbar surgery. 689 had fusions, of which 316 were transforaminal lumbar interbody fusions. Looking at the diagnostic criteria by ICD-10 code, the majority were lumbar stenosis or lytic leucesis, as well as lumbar disc pathology. The average age of the patient cohort was 55 years at surgery, with the even split between the public hospital and the private sector, and more females in the group than males. We looked at Oswestry disability data, and for the entire cohort, the pre-op score was 49% out of 100, which reduced to 28 post-op by 6 months, which was greater than the minimally clinical detectable difference and statistically significant. We looked at the Roland Morris score, which is 18 symptoms which the patient selects, and this reduced from about 12 to 7, again statistically significant and greater than the minimum clinical detectable difference. When asking about the visual analog scale, the entire cohort reduced from 6.2 to 3.7, again statistically significant. As far as the EQ5D, which consists of multiple domains, mobility, self-care, usual activities, pain, discomfort, and anxiety, and has a slider score of 0 to 100, where patients are asked to place where 100 is the best possible health, to choose a marker, and the patients went from a pre-op 54 up to 71 at 6 months. In terms of the EQ5D, what we've done is we've colored the no problems in green, severe problems in red, and you can see for all these categories, mobility, self-care, activities, daily living, pain, and anxiety, there's increased green on the right-hand side in the post-op group, with less red compared to the pre-op. So there's been a shift from higher level of disability to lower level of disability. When comparing the public and private patients, pre-op, the public were 53% and private were 46%. So this means our public patients, or our indigent patients, have a higher level of symptomatology when they report on the forms. Again, likewise, Roland Morris again showed that the public system, the indigent patients, had a higher number of complaints recognized than the private group. And if we look at this graph, the public is the dark blue, and this comes down significantly. The private is the black. It also comes down significantly in the ODI, Roland Morris, and improves in the QL Slider. So you can see, although they all improve, the public patients have a higher level of disability, and although they improve a lot, end up at a higher, post-operatively higher level than the private patients. In terms of, we looked at the subgroup analysis, we went and looked at the ICD-10 code for lumbar stenosis in primary surgery non-deformity patients. Here, the age was a little bit higher than overall at 62 years, a lot more females at more than 2 to 1. This consisted of 200 patients. And once again, you can see the pre-op dropped from 44% down to 31%. The Roland Morris 12 to 7, visual analog scale from 6 to 3. The whole slide improved from 45 to 73. And again, looking at the EQ5D, there was a general reduction in the number of reds between pre and post, and increasing green. When we compared posterolateral fusions in the primary non-deformity group, again, ODI improved from 41 to 30%, Roland Morris 12 to 7, VAS 5.7 to 3.4. The EQ5D, in terms of health slide, improved from 46 to 75. And just to represent the EQ5D, again, increasing green, reducing red. Compared to the transforaminal interbody fusion, again, we had good improvements from 45% down to 28%, Roland Morris 12 to 7, VAS 7 to 3, and EQ5D slider 46 improved to 75. And again, reduction in red, improved in green in terms of the EQ5D. When comparing the transforaminal interbody fusions with posterolateral fusions, accepting these are different patient groups with different indications and not directly comparable, there was a similar ODI post-operatively between TLIF 28% and posterolateral fusion 30. Roland Morris 7 to 7, VAS 3 to 3. But remember, these are different groups of patients, but we can achieve a similar result with these surgeries. Health slider was about the same post-operatively, and the EQ5D, again, very similar in terms of amount of green and red. So in conclusion, this is the first South African spine patient-related outcome measure study. It supports the value of surgery in degenerative spine disease. Public or indigent patients had a worse preoperative score than private, but achieved the same gain, although the private group maintained their preoperative advantage. Fusion techniques had similar outcome scores, but are not necessarily interchangeable, as they have different indications for each technique. Thank you. Good morning. I'm Robert Dunn from Cape Town, South Africa, and I'll be discussing the surgical management in previously failed pediatric deformity surgery. Spinal deformity surgery in a young patient is challenging enough, but when such surgery fails with rapid growth remaining, the consequences can be catastrophic in terms of cardiopulmonary function, never mind deformity. Management of such patients where there's been prior failed kyphoscoliosis surgery is extremely difficult, fraught with risk, and requires an individualized approach. We reviewed a small set of challenging cases in terms of strategy and outcome. In just over 1,000 deformity surgeries, we identified 9 pediatric patients that had prior deformity surgery that presented with ongoing deformity. 3 of the 9 had had early onset scoliosis, 2 of which had unexplained spondyloepiphyseal type dysplasia, 1 Sotos syndrome. 2 of the 9 had Marfan's, where 1 had undergone an anterior thoracolumbar fusion elsewhere, and 1 had undergone a posterior fusion. 3 had adolescent idiopathic scoliosis, all managed suboptimally with posterior instrumented fusions, with instrumentation failure or early removal with curved progression, and 1 patient had a failed surgery for dysplastic spondylolesthesis. All patients presented with progressive deformity and severe crankshaft in the early onset group. Both Marfans presented with pain. The one at L5 below the anterior thoracolumbar fusion, where there was residual lumbar deformity, and also pain in the spondylolesthesis case. Our strategy was dictated by the presence of fusion, and this was assessed on traction X-rays and CT scans, such as this on the right-hand side. We closely look to see if there's cross-trabeculation of the bone. This is an example where the patient had been operated on by the previous surgeons using a very simple construct, which failed. It went on to fuse in a poor position, but the discs were left intact. Such a patient where there was a posterior fusion, but the anterior column was still mobile. Multi-level osteotomies were performed through the posterior bone mass, and a distractor placed in the concavity where this was cracked open. Screws were placed by palpating the medial pedicles and free-handing them in, and good correction could be achieved with compression on the convexity and distraction on the concavity. And here's an example of a patient who had such a posterior fusion, instrumentation removed, unacceptable position to her, which created a lot of psychosocial problems, and she underwent such a posterior osteotomy and correction with a pretty good result. If the posterior fusion and anterior column were deemed rigid, then a two-stage anterior release, traction, and posterior correction were performed, and a single-stage anterior release and posterior correction performed. Here's a little boy that presented to me many years ago with a mild early onset scoliosis. At the age of 6, he underwent growth rods, which failed, were removed. He defaulted due to social issues, returned with quite a severe kyphoscoliosis, and he underwent an anterior thoracic release, placed in halo traction with counter traction with skin adhesive traction on the legs, and then subsequently a posterior correction with an excellent correction of his kyphoscoliosis. In patients that presented with pain, such as this Marfan syndrome, who had a previous thoracolumbar surgery in the UK, she presented with severe L5 nerve root pain, but the curve was rigid. At that point, I decided to simply decompress and extend the fusion to the pelvis, but she was unhappy with her body shape and ongoing costopelvic pain. I therefore did an anterior surgery to remove the implants and osteotomy, with not perfect, but reasonably happy. Of course, this is a difficult, highly dangerous surgery, and 4 of our 9 patients had surgical complications, 3 early and 1 late, all requiring revision. This 15-year-old patient with a dysplasia had undergone an anterior release with traction following his previous severe kyphoscoliosis fusion. We did the anterior release, did the traction, and took him back the following week to do a posterior correction. All went well up until day 11, when he developed in the ward an acute lower limb paralysis. And then, unfortunately, you can see on the top right over here, there's a proximal junctional failure, and you can see how he's fractured above the construct. This was revised with extension superiorly, and he recovered fully in a matter of, dramatically in a few days, and fully by about 6 weeks, and has a pretty acceptable clinical outcome. Here's a child with Sotos syndrome. He had an intraoperative loss of all signals on correction. The rods are removed, correction undone, screws left in situ, and an urgent CT scan done while anesthetized. The screws were confirmed to be good, and he awoke, moving his legs. He was taken back a week later, and a reasonable correction obtained. Here's a patient who was managed with a spondylolisthesis. You can see the halos around the S1 screws. She had an L5 S1 non-union, presented with severe low back pain and loose screws in S1. This required revision to the pelvis. So in conclusion, this is a complex group of patients with a heterogeneous etiology. It requires an individualized management strategy based on anterior column flexibility and the source of pain. It has a high complication rate, but with careful, individualized management, can have an acceptable final outcome. Thank you very much.
Thank you very much. А Роберт на связи у нас? Можно вопрос ему задать? Ребята, на связи?
Good morning, I can hear you.
Hi, Robert. Very glad to see you.
Good morning. Yes, good to see you.
We have some questions for you.
Thank you.
Hello, Robert. And so can you tell us about the osteotomy of the bone block? Yeah, or in the revision cases, you show exactly then the posterior osteotomy have a good chance for correction. And according to your experience, could you share us how many levels you would recommend us for the osteotomy? 2, 3, or every level osteotomy to achieve the mobility of the spine in this type of the patients? And what the percent of neurological complication, or which type of the complication is available to have in this situation? Because it's bone block after the many of years of fixing spine, and we do the osteotomy after the several years of the previous surgery. Is it affected on the spinal cord, or it's the similar like a primary surgery?
Thank you for the question. Look, it's actually amazing. Sometimes you get into the back and you start taking the bone off the back and you realize the fusion has not actually taken. The facet joints are still mobile. The previous surgeon didn't actually do a facetectomy, and then it's relatively easy. Sometimes even the bone overlaps like that, and once you take the top off, you can see the fibrous tissue. But in the case I showed there, I would generally do about 3 or 4 osteotomies spread over the most severe part of the deformity. And I generally use a burr and I run across because I want to cut that bone out and use it for bone grafts. So I just cut the block and then I use a cape and a gouge and I chisel it out. And then what I do in the concavity is I often put a distractor, and with the distractor I slowly open it and it eventually cracks open on the concavity. So that's how I do it, and I don't use any spinal navigation. It's all freehand. So what I do is I then palpate the pedicle from the canal, and then I put my screws in under. I can feel where the pedicle is, and I put my screws in like that. I have not had a neurological complication with that osteotomy type situation. My complications has always been correction of kyphosis. And both those children I showed with a proximal junctional fracture and the other Sotos syndrome were kyphotic corrections. And I think that is the most dangerous, where you've got maybe some scarring down of the thecal sac inside the canal. It's not as resilient. It's much more sensitive to tension. So, as I say, I think this group of patients is a much higher risk than your primary care. But when with a straightforward AIS, when I did bone block cuts like that at the back, I haven't not had a problem. So I think that's relatively safe.
Thank you very much. I want to ask you one question. Now it's very popular compare with result surgical follow-up between different races. For example, Asian and Caucasus. You have big experience in black population people. What can you say about results in degenerative disease follow-up results after surgery between white and black people? Maybe you noticed any difference?
Yeah, look, firstly, the reason we did that study is because our funders, the way the private and state funding work, there's a lot of people who believe we're wasting money on spinal surgery. The funders see a lot more surgery happening around the world and so on. So we wanted to show that we actually make a difference. So we show we make a difference. I did not particularly study race because it's a very sensitive topic in our country. And in fact, if you want to study race, you will not get ethical approval. But I do think, for me, I don't think there's a difference in race, in my perception. I think the difference is in social economics. But obviously, in some countries like ours, there's a combination of, our black people largely have low socioeconomic associations because of our history. But if I look at it, if you're a wealthy person and you're in the private sector, you do better than if you're a poor person in the public sector. Now, I did all the surgery, so the surgery was the same, the techniques are the same, but of course, PROMS is a personal perspective of things. And I think if you're in the public service, often you're doing manual work, you labor, your options after spinal surgery are different. If you are in the private sector, often you're in an office, in administration, your environment after surgery is different. So I think that's what we're seeing in the difference in the public and private. It's socioeconomics, but it's really your ability to cope with life after your fusion, and depending where you are in society, your options are different. So I think that's all we're seeing. But in terms of race, purely, I don't think there's any difference.
Thank you very much. Может быть, кто хочет спросить?
Can I say something? We don't have much difference in race because, Brazil has all races. The problem is fat and thin patients.
Thank you very much, Robert.
Okay.
We
Bye-bye.
are all very glad to see you. I hope
Good. Okay, I look forward to coming to Moscow again. Cheers. Bye-bye.
We can see you face to face. Thank you very much. Дальше у нас Виктор Викторович Рерих. Хирургическое лечение повреждений грудно-поясничного отдела позвоночника. Surgical treatment of traumatic fractures of thoracolumbar spine.